It's a question for David. Nepalese migrant workers working nephropathy. Are you aware?
I didn't catch the whole question, but I think I got the thrust of it. Yes, there have been very few studies, but clearly after the World Cup in 2022, thousands of migrant Nepali workers returned home from Qatar and were found to have severe renal failure. It's a really interesting and sad natural experiment because in many ways, their sole exposure was to heat. They're not exposed to agrochemicals. They're not exposed to heavy metals. They're not exposed to various other things. So in many ways, yes, I think it's a similar phenomenon. And I think it will be potentially a much cleaner cause and effect relationship. But in fact, as far as I'm aware, there is not one peer-reviewed paper trying to figure out how common this was or really understand the details. But certainly newspapers and abstracts and various reports strongly support the idea that thousands and thousands of Nepali workers suffered severe kidney injury working in 125-degree heat, preparing the stadiums for the World Cup.
We do have one question for Dirk. Is it better to do surveillance angiograms after initial failed or repaired AV access, or just intervene when there is a problem?
It's neither. The best thing is that you do, or somebody in the dialysis unit does, expert physical exams in regular intervals, and by physical exam identifies accesses that need an intervention. So, it's very clear CMS does not support surveillance angiogram, and waiting until things happen usually means that catastrophe abounds, and it's often skin breakdown, infection, loss of access, catastrophic bleeding. So there has to be this middle road, and it has to, and the easiest, let's say, resource conserving way is developing physical exam skills and then examining accesses regularly. Yeah.
Okay. There's another question. How do you treat in-catheter thrombosis?
I didn't catch the, so
catheter
how do you...
associated thrombosis. How do you treat catheter?
So the studies are pretty clear that tunneled catheters, at least in 40%, have angiographically identifiable thrombus hanging on their tip. And we know that 100% of tunneled catheters have a fibrinous sheath, and that fibrinous sheath is tethered in different places to the vessel wall, and that is associated with some thrombus formation. So the vast majority of this type of thrombus is not associated with clinical events that are noticeable or measurable. If you have larger intraatrial, intracardiac thrombus, it is often clinically prudent to attempt a period of anticoagulation. But if you remove the catheter or not remove the catheter, often this thrombus has very strong wall attachment and does not resolve with anticoagulation. The issue of infected intraatrial or catheter-associated thrombus becomes a little bit more complicated because you do need to remove or exchange this catheter, and there is always clinical concern, and it certainly happens, that during the exchange or removal, some of that thrombus will embolize into the lung. There is an opinion-based recommendation that thrombus that is larger than, I believe, 2 centimeters should be removed in a controlled fashion, and there are devices that allow to do this. But the immediate blood loss, because of the high suction and force associated with these, is about 1.5 liters. So these are procedures not for the faint of heart, and they have to be planned appropriately, and they're usually done in a cardiology suite. They use these devices usually in that setting or in the IR departments for massive pulmonary emboli. So that's a cross application in that world. But the vast majority of thrombus associated with the catheter tip is probably benign, and the thrombus seen in internal jugular veins, where a catheter placed, is physiologic. So the catheter occludes the vein, thrombus has to form. So there is, if it occludes the vein, there's no flow, so you have stagnant thrombus, so there will be some thrombus. It can be symptomatic with redness and tenderness. Well, then you have to add anticoagulation. But if the catheter is needed, don't remove the catheter, because the patient is at higher risk of developing thrombus anywhere where you put the line. If you remove a catheter, you will always have thrombus at the removal site. So again, it's physiologic, because otherwise you would continue to bleed. There is not only a scab visible from the outside, but there is also thrombus on the inside. That is actually what seals the vessel from the inside. Similarly, anytime you pull a needle out of a fistula, there's thrombus on the inside. If you look half an hour after pulling the needle out with an ultrasound, there's a piece of thrombus inside the access. And that has to be there. But it's also a reminder of why you want to rotate, because that thrombus takes time to resolve. And if you put the needles in the same spot, you get more and more thrombus, and you may get occlusion, like in a graft, for instance. But coming back to the tunneled catheter, so the frequent finding is that you get a CT scan, the tunneled catheter is there, and it reports there's thrombus in the internal jugular vein or in the subclavian vein as the catheter goes by. Unless there's symptoms, I would not treat them. As there's ample documentation that dialysis patients are much more prone to bleeding events. If they are symptomatic, then you have to make a decision: is the catheter needed or not? If it's needed, don't remove the catheter, use anticoagulation, and see if you can find a different way to dialyze them.
Terrific answer. Do you recommend surveillance fistulograms?
I think it's similar to the first question. I recommend surveillance physical exams. So it's a skill that nephrologists should learn. Also, and this is kind of a gap at the moment, people in the dialysis unit, nurses, technologists working there, technicians, would benefit from developing this skill set. And organizationally, you could have a pod structure where a nurse is responsible for 10 or 15 patients, and they do the physical exam, so that they know, oh yeah, this looks different, this feels different. So there are ways to kind of, I think, improve our care of dialysis access in for-profit and non-for-profit dialysis units.
The last question is for Adina. How practical is it for a nephrologist to do POCUS?
So utility, yes, it is very helpful. So that is a question of should you do it, and how practical, if you mean how much time does it take. So for the learned, if you have learned to use the skill and you have an available ultrasound, and you may see that I have a little device that I always carry in my pocket, it takes maybe 5 minutes. I'm not exaggerating. Obviously, the training part is a little bit longer, and you do have to invest quite a bit of time to learn it. Once you've learned it, it is quick and it is helpful.
On that note, I think we will finish the question and answer section. Thank you to all three of you for a very interesting session. And just to wrap up, I'd like to thank all the other course directors, Adina Wojciechowski, Garode McMahon, Alice Sheridan, and Jamil Ozzie. Many thanks to Michelle Durrani and Stephanie Trang Nguyen for their tireless work in arranging the course, inviting all the speakers, making sure all the logistics are well handled. The AV team today and all through this week were really wonderful. And we look forward to seeing you next year for this course. Please do remember to do your evaluation so that you do get CME credit. And thank you very much for listening to us.